Ladies and gentlemen, thank you again for Medtronic for inviting me to give a talk about mitral valve surgery. I will talk about our procedure in the Yilmaz hospital. It's a totally endoscopic mitral valve repair. In fact, the next step in a non-utility port procedure. The Yilmaz hospital is in fact in Belgium, small country, well known. In fact, on the east of the Belgium side, and it's an hospital about 1,000 beds, and we are performing quite a lot of minimal invasive cases. What about the minimal invasive mitral valve surgery? As we all know, mitral valve surgery is already a century ago started by Elliot Carr. He performed the first closed commissurotomy with a special knife to a transventricular approach. A few years later, his colleague Henry Sutter performed the transauricular commissurotomy with his fingers. And you see a very nice picture over here. This is in fact done till a few decades ago in some part of the world. In fact, a heart surgery with a patient in an ice bath. But of course, this is not done in the European countries. With the arrival of the first cardiopulmonary bypass, Professor Starr performed the mitral valve replacement with a mechanic valve. Meanwhile, of course, in Europe, Professor Carpentier didn't sit down like looking to the Americans, and he started to perform a mitral valve repair. The well-known French correction by Alain Carpentier, resection, sliding, we all know all those procedures. He had a very good results. Long-term follow-up showed freedom from re-op in 15 years of almost 90%. Meanwhile, the Canadian Tyrone David came up with the American correction by using the PTFA course of the Inea Corday. And also he had a very good long-term follow-up with the freedom of re-op of 90%. And why are we doing minimal invasive cardiac surgery? Cardiac surgery, conventional cardiac surgery, we perform a sternotomy, and we do that just to see a small valve, in this case a mitral valve of some square centimeters. To get to the mitral valve you need a sternotomy. Of course, the surgeons knew all the disadvantages of a sternotomy, and in the 90s, early 90s, they started to do some another attempts to minimal invasive cardiac surgery by performing an upper, the lower, J sternotomy, T sternotomy, reverse T, just not to have to do a sternotomy. And then you get this kind of scarrings, smaller incisions by the skin, but still not a good result, because not all patients were eligible for this kind of procedures. And still now, more than 90% of the mitral valve surgery is performed by sternotomy. Meanwhile, in our surroundings, our colleagues have quite good technology tools to perform distance surgery, like in this case a flexible endoscopy. Also, we, the surgeons, have kind of endoscopes, flexible, semi-flexible, but still there is a rigid shaft. With that, we can perform some kind of minimal invasive surgery. We also have 3D vision, what might help in some cases. And of course, the robot, the Da Vinci, is also present for almost 2 or 3 decades. Again, we have the robot, but I don't use the Da Vinci system. Why the mix? Because our colleagues, where we collaborate a lot, the cardiologists are getting more and more invasive. So we should be less invasive, otherwise in 10 or 20 years time you won't have any patients. And we know that the first results of minimal invasive surgery was good. Patients are searching in by internet, look into the results, and also they want a minimal invasive surgery. And there is in Belgium about 28 centers, and there's a lot of competence between the centers. That's why we should be in front performing new surgery other than the other centers to get the patients. We should never forget the quality of care, because every outcome you might perform should be compared to the standard surgical outcome as a gold standard. The first surgery published was done by Professor Moore in 1996, where he performed the first 51 patients by a right thoracotomy. Again, in that time it was great news, because he could do mitral valve surgery to minimally invasive approach in almost all cases. And when you look to the results, there was a mortality of about 10%, quite a lot of complications. Still, it was revolutionary. And he performed, in this case, by minimally invasive approach, more than half of the patients by repair. The cardiac arrest can be performed by the intra-occlude aortic balloon occluder by Edwards, or a simple transthoracic clamping, the Chitwood clamp. Here you have a very nice view of the technique, or we call it the Leipzig technique of port access mitral valve surgery. Patient is lying in his decubitus dorsalis, and they performed a thoracotomy about 6 to 8 centimeters with the use of rib retraction. And there is a camera, and the camera is mainly used for a light source. It's in fact a procedure by direct vision. Why is that? Because in any cases of mitral valve surgery, you need an atrial retractor. You need to pull up the left atrium, in fact intra-atrial groove, to get view on the mitral valve in the left atrium. Otherwise it's impossible to see the mitral valve when you use, of course, direct vision. This is in fact the retraction of the rib, but you have to open it for at least 5 or 6 centimeters. In fact, it's an anterolateral thoracotomy, as we do in lung surgery. There are surgeons who resect the rib. I find it a mutilation for a patient's chest. And this is also minimally invasive in some eyes. When you use a robotic, even in a robotic, you need a thoracotomy to get the instrumentation, valves, name it, intrathoracic. In the Jesse Hospital, we performed the totally closed chest mitral valve repair, the so-called MVATS. It's in fact a procedure where we get to the heart by 3 ports of 5 to 15 millimeter of diameter. All our procedures are performed by double cannulation, in fact the inguinal and a jugular venous cannulation, and an arterial cannulation by the groin or in needed subclavian artery. This is a post-op view of the scarring of the patients. As you see, 3 small incisions of 5 millimeters to 1.5 centimeters. In fact, the incisions or scarring are less than any thoracic surgery. This is the procedure itself. We perform, as you see, by endoscopic tools, opening of the pericardium, putting retraction sutures for the pericardium to have a better view on the heart. The heart is arrested, the left atrium is opened to get a better access to the mitral valve. The mitral valve is placed, get better view by 2 stitches on the commissures, and after putting the stitches on the mitral annulus, we inspect the mitral valve on the classic way to see if we can see any structural problems. Next step will be put stitches through the mitral ring. It's a semi-flexible ring. We can push through the thorax inside the left atrium, and then the knots, or the sutures, can be knot by the automatic knotting device, the so-called core knot. This is a very useful tool for putting notches in the depth Checking the valve will let you see if there's any structural problem. You can correct it, and once the mitral valve is patent, then we can close the left atrium. This was one of my first patients I performed more over than 10 years ago. I was a bit younger, black hair, laughing more, I think, less serious about that now. But anyhow, this was my first patient. Since 2013, I performed in the ESSA hospital more than 250 cases, mainly mitral valve repairs, but also combinations with tricuspid or rhythm surgery. And people say that the first series are almost the series with the largest problems, long clamping times, procedure times. But again, in our series, we've seen that our first 25 series were comparable, maybe better than the first large port access or robotic series. And when we look to the last 25 isolated mitral valve repairs, it's comparable like an open surgery. When we follow those patients, we've seen that we had mortality of 2 patients, one because of pleurodesis and anaphylactic shock on it, and 1 patient had AV dissociation after mitral valve repair. We had 2 conversions because of mainly bleeding. We had also MVATS for bleeding by intercostal artery and use of NOACs. And the blood loss post-op was better in the last 20 patients, still much better than open cases. And hospital stays is about 1 week. We had 3 patients with a recurrence MI grade higher than 2. We had to operate on. We had done 2 re-repairs by endoscopy, and 1 needed a mitral valve replacement. Endoscopic surgery, especially good for this kind of patients who are very obese with a small thorax. And if you need to do a thoracotomy in this patient, your thoracotomy will be at least 15 centimeters to get a good view on the mitral valve, because the distance between the skin and the valve is very far, while your incision should be larger. And this patient don't need to have a big thoracotomy because of the complication that might rise. Another endoscopic approach was performed after post-pneumonectomy and a pectus patient. In pectus patient, it is impossible to perform the port access because of the non-use of, you cannot use the atrial retractor because you cannot tilt up the heart because of the sternum. Here again some pictures of the 3 techniques. On the left side, the conventional technique we all know. In the middle, the so-called port access technique, what I don't use because of the thoracotomy and the complication you might see. On the right side, the ESSA experience or the ESSA technique with just endoscopy. As a conclusion, we can say that our data are comparable, maybe better than the present large series of port access and robotic techniques. Our patients have really no pain at all, and that gives that they can start with early rehabilitation and return to daily work. There's still space for improvement, like the automatic knotting devices, or in the future already rapid deployment valves. Endoscopy is available in every center and it is cheap. You cannot say that from the robotics because it's very expensive. And in minimally invasive surgery, cosmesis is still an important factor not to forget. And our endoscopic technique opens also room for a hybrid procedure. It's a non-stenotomy approach for combined procedures with coronary disease. And here you can see that the mitral valve is done by right side endoscopic, and on the left side the CABG is done by mini thoracotomy approach. This is my presentation about our technique of endoscopic mitral valve repair. Thank you again for your attention.